Psychotic disorders represent a significant departure from external reality, often marked by hallucinations, delusions, and disruptions in speech and behavior. This presentation delves into the intricacies of these conditions, exploring their defining features, the distinctions between different types, and the pharmacological strategies employed to address these multifaceted mental health issues. Psychosis encompasses a wide range of symptoms, including agitation, pressured speech, and flight of ideas. Hallucinations, which can be visual, auditory, tactile, olfactory, gustatory, or proprioceptive, are common. Delusions, such as those of persecution, grandeur, or control, may also occur. Additionally, individuals may experience apathy, social withdrawal, anhedonia, and diminished speech. Schizophrenia. This disorder affects approximately 1% of the global population and is characterized by a significant decline in social and occupational functioning. Individuals with schizophrenia often experience hallucinations, delusions, disorganized speech, and other symptoms. Unfortunately, they are expected to live approximately 2 decades less than the average population due to a variety of factors, including increased risk of suicide and medical comorbidities. Schizophreniform disorder. Considered a precursor to schizophrenia, this condition shares many similarities with schizophrenia, but typically lasts for a shorter duration, usually between 1 to 6 months. Individuals with schizophreniform disorder are at an increased risk of developing full-blown schizophrenia. Brief psychotic disorder. This disorder involves a brief period of psychosis, typically lasting less than 1 month. It is often triggered by a specific stressor or traumatic event. Unlike schizophrenia or schizophreniform disorder, individuals with brief psychotic disorder are not expected to progress to develop schizophrenia. Schizoaffective disorder is characterized by the presence of psychotic symptoms such as disorganized speech, hallucinations and/or delusions, along with mood disorder symptoms like depression, mania, or mixed episodes. This combination of symptoms makes it a complex and challenging condition to manage. Treatment for schizoaffective disorder typically involves a combination of cognitive behavioral therapy, CBT, and atypical antipsychotic medications. These medications are preferred because they possess inherent mood-stabilizing properties, helping to address both the psychotic and mood-related symptoms. However, managing schizoaffective disorder can be more complex than other psychotic disorders due to the limited number of medications approved by the FDA specifically for this condition. As a result, finding the right treatment approach often requires careful consideration and may involve a trial and error process. It's important to note that individuals with schizoaffective disorder often experience a more severe course of illness and a poorer long-term prognosis compared to those with schizophrenia or mood disorders alone. Therefore, early intervention and comprehensive treatment planning are essential for improving outcomes and enhancing quality of life for individuals with this disorder. Antipsychotic medications play a crucial role in the management of psychotic disorders, helping to alleviate symptoms and improve overall quality of life for individuals affected by these conditions. There are 2 main categories of antipsychotics, typical and atypical. Typical antipsychotics, also known as first-generation or conventional antipsychotics, were among the earliest medications developed to treat psychosis. While effective in controlling symptoms, they are associated with a higher risk of extrapyramidal side effects, EPS, such as Parkinsonism and tardive dyskinesia. Despite their efficacy, their use has declined in recent years due to these side effects. Atypical antipsychotics, also known as second-generation or novel antipsychotics, are newer medications that have become the preferred choice for treating psychotic disorders. They offer several advantages over typical antipsychotics, including a lower risk of EPS and a broader spectrum of efficacy, particularly in managing negative symptoms. Atypical antipsychotics are generally considered safer and better tolerated by patients. Clozapine stands out as a unique antipsychotic medication, often reserved for individuals with treatment-resistant schizophrenia or those at high risk of suicide. While highly effective, clozapine is associated with a distinct side effect profile, including potentially serious adverse effects such as granulocytosis, myocarditis, and cardiomyopathy. Despite these risks, clozapine remains an important treatment option for individuals who have not responded to other antipsychotic medications. Typical antipsychotics, also known as first-generation or conventional antipsychotics, were among the first medications developed to treat psychotic disorders. While effective in managing symptoms, they are associated with a higher risk of extrapyramidal side effects, EPS, including Parkinsonism and tardive dyskinesia. Here are some examples of typical antipsychotics. 1. Chlorpromazine. This is a low-potency typical antipsychotic with antiemetic properties, making it useful for managing nausea and vomiting. However, it carries a higher risk of cardiovascular side effects and extrapyramidal symptoms compared to other typical antipsychotics. 2. Fluphenazine. Fluphenazine is a high-potency typical antipsychotic, meaning it has a stronger binding affinity for dopamine receptors. As a result, it is associated with a greater risk of extrapyramidal symptoms, including Parkinsonism and tardive dyskinesia. 3. Haloperidol. Haloperidol is another high-potency typical antipsychotic commonly used in the treatment of psychosis. It has a high risk of causing extrapyramidal symptoms, but is available in an intramuscular (IM) formulation, making it suitable for emergent situations where oral administration may not be feasible. Atypical antipsychotics, also known as second-generation or novel antipsychotics, represent a newer class of medications used to treat psychotic disorders. They are preferred over typical antipsychotics due to their lower risk of extrapyramidal side effects, EPS, and superior control of negative symptoms. Here are some examples of atypical antipsychotics. 1. Aripiprazole. Aripiprazole acts as a partial dopamine agonist and partial 5-HT1 agonist, which helps to rebalance neurotransmitter levels in the brain. It is associated with a decreased risk of metabolic side effects such as dyslipidemia, insulin resistance, and diabetes compared to other atypical antipsychotics. 2. Clozapine. Clozapine is considered the drug of choice for treatment-resistant schizophrenia and individuals at increased risk of suicidality. However, it is associated with a unique side effect profile, including a granulocytosis, a severe reduction in white blood cell count, myocarditis, and cardiomyopathy. Due to these risks, close monitoring is essential when prescribing clozapine. 3. Quetiapine. Quetiapine is a dopamine 5-HT2A antagonist with sedative properties, making it beneficial for patients with insomnia. However, it also carries a risk of metabolic side effects, similar to other atypical antipsychotics, which should be monitored closely during treatment. Extrapyramidal symptoms, EPS, are a common side effect associated with the use of antipsychotic medications, particularly typical antipsychotics, due to their strong binding properties to dopamine D2 receptors, especially in the nigrostriatal dopamine pathway. Here are some approaches to managing EPS. 1. Anticholinergic, antimuscarinic agents. Medications such as benztropine or diphenhydramine are commonly used to alleviate the dysfunctional motor activity caused by EPS. These agents work by blocking the action of acetylcholine, which helps to rebalance neurotransmitter activity in the brain and reduce EPS symptoms. 2. Antihistaminic agents. Certain antihistaminic medications, such as diphenhydramine, can also help alleviate EPS symptoms by blocking histamine receptors in the brain. This action can help mitigate the motor disturbances associated with EPS. 3. Dopamine agonists. Dopamine agonists, such as pramipexole, can be used to counteract the dopamine antagonist effects of antipsychotic medications and reverse EPS symptoms. By stimulating dopamine receptors, these medications help to restore normal neurotransmitter activity and alleviate EPS. Overall, the management of EPS involves a combination of pharmacological interventions aimed at rebalancing neurotransmitter activity in the brain and alleviating motor symptoms associated with antipsychotic use. Close monitoring and individualized treatment plans are essential to effectively manage EPS while optimizing the benefits of antipsychotic therapy. Tardive dyskinesia, TD, represents one of the most severe presentations of extrapyramidal symptoms, EPS, characterized by involuntary and repetitive movements such as lip smacking, grimacing, and excessive blinking. It commonly occurs as a side effect of long-term use of antipsychotic medications, particularly typical antipsychotics. Management strategies for tardive dyskinesia include 1. Switching to clozapine therapy. Clozapine, an atypical antipsychotic, is often recommended as an alternative medication for individuals experiencing tardive dyskinesia. Clozapine may help improve existing TD symptoms as it possesses a different receptor binding profile compared to typical antipsychotics. 2. Early removal of D2 receptor blockade. Early intervention to remove or minimize D2 receptor blockade, such as by discontinuing the offending antipsychotic medication, can help reverse tardive dyskinesia. This approach aims to restore normal dopamine neurotransmission and alleviate TD symptoms. 3. Importance of early intervention. Tardive. Dyskinesia has a high probability of becoming permanent or irreversible if not addressed promptly. Therefore, early recognition and intervention are crucial to prevent the development of this debilitating movement disorder and improve long-term outcomes for affected individuals. In summary, the management of tardive dyskinesia involves a proactive approach that includes switching to alternative antipsychotic medications, minimizing D2 receptor blockade, and advocating for early intervention to prevent permanent impairment. Close monitoring and individualized treatment plans are essential to effectively address TD and optimize patient outcomes. Neuroleptic malignant syndrome, NMS, is a severe and life-threatening reaction that can occur in response to antipsychotic medications. It is characterized by a constellation of symptoms including muscle rigidity, tremors, hyperthermia, autonomic instability, and altered levels of consciousness. Management of NMS involves several key strategies. 1. Immediate cessation of the offending agent. The first step in treating NMS is to discontinue the antipsychotic medication that triggered the reaction. This helps prevent further exacerbation of symptoms and allows for the initiation of appropriate treatment. 2. Supportive care. Supportive measures such as hydration, temperature control, and monitoring of vital signs are essential to stabilize the patient's condition and prevent complications. 3. Pharmacological treatment. Medications may be administered to address specific symptoms of NMS. These may include dantrolene, which helps reduce muscle rigidity and hyperthermia, bromocriptine, a dopamine agonist that can alleviate symptoms, and benzodiazepines to manage agitation and anxiety. 4. Differential diagnosis. It is crucial to differentiate NMS from other conditions with similar presentations, such as malignant hyperthermia and serotonin syndrome. This differentiation is important as the treatment approaches for these conditions may vary significantly. In summary, neuroleptic malignant syndrome is a serious adverse reaction to antipsychotic medications that requires prompt recognition and intervention. Early cessation of the offending agent, supportive care, and pharmacological treatment are essential components of management, along with careful consideration of differential diagnoses to ensure appropriate care for affected individuals. Dopamine, a neurotransmitter in the brain, plays a pivotal role in regulating movement and behavior. Imbalances in dopamine activity can contribute to a range of movement disorders and psychiatric symptoms. 1. Excess dopamine activity. In conditions like schizophrenia, excess dopamine activity in the mesolimbic pathway is implicated in the development of positive symptoms such as hallucinations and delusions. Additionally, frenetic movements like chorea, tics, and vocalizations are associated with dopamine excess as observed in Huntington's disease. 2. Dopamine depletion. Conversely, a depletion of dopamine in the substantia nigra is characteristic of Parkinson's disease. This deficiency leads to motor symptoms such as bradykinesia, slowness of movement, rigidity, and postural instability. Medications like levodopa and dopamine agonists are used to alleviate these symptoms by increasing dopamine levels in the brain. 3. Antipsychotic medications and EPS. Antipsychotic medications, which block dopamine receptors, can inadvertently lead to extrapyramidal symptoms, EPS, resembling those seen in Parkinson's disease. To manage EPS, anticholinergic medications and dopamine agonists may be prescribed to counteract the effects of dopamine blockade and restore balance to the motor system. Understanding the intricate relationship between dopamine and movement disorders is crucial for the effective management of psychiatric symptoms and movement abnormalities. By modulating dopamine levels and receptor activity, clinicians can help alleviate symptoms and improve the quality of life for individuals affected by these conditions. Dopamine, a neurotransmitter implicated in various brain functions, plays a central role in the pathophysiology of psychosis, particularly in schizophrenia. Understanding the complex interplay between dopamine pathways is crucial for elucidating the mechanisms underlying psychotic symptoms and developing targeted treatment strategies. 1. Mesolimbic pathway. Excessive dopamine activity in the mesolimbic pathway, which projects from the ventral tegmental area, VTA, to the limbic system, is implicated in the genesis of positive symptoms of psychosis, including hallucinations and delusions. Dysfunction in this pathway is believed to contribute to the aberrant salience and perception characteristic of psychotic disorders. 2. Mesocortical pathway. Conversely, hypoactivity in the mesocortical dopamine pathway, which projects from the VTA to the prefrontal cortex, is associated with the development of negative symptoms, e.g., apathy, social withdrawal, and cognitive deficits observed in schizophrenia. Impaired dopaminergic transmission in this pathway is thought to underlie deficits in executive function, working memory, and attention seen in psychosis. 3. Antipsychotic medications. Antipsychotic drugs exert their therapeutic effects by modulating dopamine neurotransmission, aiming to restore the balance of dopaminergic activity in specific brain regions with dysfunctional circuitry. By antagonizing dopamine receptors, particularly D2 receptors, in the mesolimbic pathway, and potentially enhancing dopaminergic activity in the mesocortical pathway, these medications help alleviate positive symptoms while potentially ameliorating negative and cognitive symptoms. By targeting specific dopamine pathways implicated in psychosis, antipsychotic medications offer a means of rebalancing aberrant neurotransmission and ameliorating symptoms associated with psychotic disorders. However, the precise mechanisms underlying their therapeutic effects remain the subject of ongoing research and debate. Chlorpromazine, a D2 antagonist, is primarily indicated for schizophrenia and psychosis. Its mechanism of action involves blocking dopamine receptors, contributing to its antipsychotic effects. However, notable side effects include cardiovascular issues, extrapyramidal symptoms, EPS, sedation, and weight gain. Fluphenazine, another D2 antagonist, is also used for schizophrenia and psychosis. Like chlorpromazine, it acts by blocking dopamine receptors, but it is associated with side effects such as EPS, sedation, and weight gain. Haloperidol, a D2 antagonist, shares similar indications with chlorpromazine and fluphenazine. It exerts its antipsychotic effects by blocking dopamine receptors, but it is notorious for causing EPS, sedation, and weight gain. Aripiprazole, a partial D2 agonist and 5-HT1 agonist, is used for schizophrenia and bipolar disorder. Its unique mechanism of action involves partial activation of dopamine receptors, resulting in decreased metabolic side effects compared to other antipsychotics. Clozapine, acting as a D2-JAK5-HT2A antagonist, is specifically indicated for treatment-resistant schizophrenia and schizoaffective disorder. However, its use is limited due to severe side effects such as agranulocytosis, myocarditis, and cardiomyopathy. Quetiapine, also a D2-5-HT2A antagonist, is prescribed for schizophrenia and bipolar disorder. It is known for its sedative effects and can cause metabolic side effects similar to other antipsychotics.